Ladies and gentlemen, thank you for standing by and welcome to the Cultural Humility Contact Tracing Training. At this time, all participants are in listen-only mode. You may submit a question through the WebEx chat box and answer will be provided afterwards. I would now like to hand the conference over to Anne Margaret Foley. Thank you, ma'am. Please go ahead.
Good afternoon, everybody. Good afternoon to all our virtual support staff. We want to welcome our contact tracers, our contact tracer supervisors, and our community support specialists. We are very pleased to welcome you all today to attend the training on cultural humility and contact tracing. I'd like to introduce Neveline White, Megan Carroll, Simone Campbell, and Paul Santos. Neveline, Megan, and Pauline are all from the New York State Department of Health. Simone Campbell is one of our contact tracing supervisors today. We are so pleased to have the four of them present on this very important topic, and we hope that you receive a lot of information that helps you work with all the contact tracing teams and your individuals that you're going to be assisting across this New York State who will be having a vast number of different diverse individuals that you'll be working with from a vast different cultural backgrounds and norms. So I think that you're really going to enjoy this training and really learn a lot from it. And please, if you have any questions following, if we don't have time at the end, make sure that you submit them because we want to have an FAQ document following this. Thank you, and I'd like to turn it over to Megan.
Thanks, Anne Margaret. Hello, everybody. My name is Megan Carroll, and I just want to thank you again for joining our training today. I'm going to go through quickly just a quick disclosure. Today's training is really meant to be an introduction to the topic of cultural humility. As you'll learn through our conversation today, this is a really lifelong, evolving practice, and today is meant to give you just an introduction that is necessary for your work as a contact tracer. The information we're going to share today builds on a lot of existing work that we've done here at the New York State Department of Health, along with some of our collaborative partners. We also want to stress that self-care is very important during this time for both your mental and physical health, as some of the things that we're going to discuss today can be very difficult for people, and I'm sure, as all of you know, some of this work can be emotionally draining. So we want to make sure that you take the time to really take care of yourself during this process. And of course, as you'll see, the context, obviously, during the COVID-19 pandemic is something that we're going to discuss. Just for all of you who are watching, we are advancing the slides, so you should be able to see the slides through the WebEx and hear us on the call. So a quick agenda for today's call. We've done our introductions. We're going to go through some definitions and terms that we're going to discuss, talk a bit about COVID-19 and how the pandemic has really highlighted a lot of existing health disparities with New York State residents. We're going to talk a bit about intersectionality and how different cultural norms, behaviors, and lived experiences are impacting the lives of the folks that you're going to talk about. And then we're going to talk a bit about how this actually impacts your day-to-day work as a contact tracer. As Anne Margaret mentioned, these are today's speakers. Myself, Megan Carroll, Neveline White, Pauline Santos all work for the Department of Health, and Simone Campbell is a contact tracing supervisor. Contact tracing, as you are all well aware, is a very difficult and complicated role, one that's incredibly important during this pandemic. It's sort of a unique job where you're asked to talk to people during what can be a very challenging and difficult time period in their life. And better understanding where those individuals come from, their lived experience, and how that helps them access health care, how that impacts the way that they're going to speak with you and react to some of your questions is going to help make all of you better contact tracers in the future. So, one of the questions we like to start out with is, why does this matter? Why is it important to talk about culture and cultural humility in terms of this contact tracing position? And it's really important to remember, if we don't meet people where they are, if we don't lead with empathy, we won't be able to fully connect with them. And you are going to be calling a very ethnically, racially, culturally diverse group of individuals. And by understanding where people come from, you're going to have an easier job connecting with them and completing your tasks as a contact tracer. Many of the people you contact may already be anxious, scared, even defensive, and they may not recognize that some of the cultural differences that we have could alienate the people on the phone. So hopefully through today's training, it will help us to better understand how each person, both you, the contact tracer, and the folks that you're speaking to on the phone, bring their own lived experience to the situation. And better understanding those unique circumstances will help you meet the needs of the individuals that you're calling. So I'm just going to pause right here and mention one more time. If anybody has any questions throughout the training, please feel free to type them into the Q&A box. If we have time at the end, we'll try and address some of those questions. If we don't have time, we will work on putting in an FAQ document or something else out. So hopefully many of you have heard the term cultural humility before. I know that it's something that might sound relatively new. It's a term that's evolved in the 1990s, and it's something that's evolved to replace what you may have already been familiar with, the kind of cultural competence or cultural sensitivity training. Here's a definition of cultural humility, and I really want to stress a couple of things about this. The first part is, unlike cultural competence, humility really recognizes that we don't know everything. It's impossible for one person to know everything about every different culture. It also asks us to really be honest about where we come from and our own limitations. The expectation isn't that we or you are going to know everything. This is an ongoing process that's going to require lifelong learning. And what it really strives to do is build trust. One of the things I hope you'll see through this training is that many of the different people that you're going to talk with through your work are people who come from different cultural backgrounds that may have had a history of being marginalized or oppressed. They may be people who really don't have a strong trust or faith in healthcare systems or government institutions. And part of our work is really trying to rebuild some of that trust. So as I mentioned, cultural humility is an ongoing process. People and communities change over time. If you even just think about the neighborhood that you grew up in as a child, the neighborhood that you live in today, the demographics and the culture of the people who live in that neighborhood change every 5 years, 10 years, 20 years. And so we always have to be open to learning. We have to be open to understanding the experience of those people. As I mentioned, there's no such thing as competence. There's no sort of magic threshold that we're going to hit. We have to always be open to understanding and growing in this process. A big part of this is self-reflection, and we'll talk more about this, but it's really starting with a deep understanding of yourself, of where you come from, how your culture and background shapes your beliefs, how it shapes your behavior. And that'll make us more aware and empathetic to how culture shapes the behavior of the people we work with. Don't be scared to say, I don't know. We're not expecting everyone to be an expert on different cultures and different lived experience. Being honest and saying that we don't know, having the humility to admit that, will put you into a place to help you better understand the people that you're working with. Finally, as you'll see, and I mentioned before, we're going to talk with people who represent groups who really are some of the most historically and generationally disenfranchised or marginalized groups of people in this country. And these are people who, with the intersection of the COVID pandemic and other things that are happening across our country, have really been bombarded by a lot of these inequities. And a lot of this stuff may be very fresh for people, may be very raw, and we have to make sure that our work is helping to rebuild that trust, to connect these people to the resources they need, and to help them become healthier. There are 3 conditions that are associated with cultural humility, as I mentioned. The lifelong learning and self-critique. Again, that desire to fix power imbalances, to recognize that everybody brings something different. We may be experts in how to do contact tracing, but the folks on the phone are experts in their communities and in their lived experience. So we really have to be open to accept and to utilize the expertise that those folks bring to this interaction. And we also have to develop partnerships with people and groups who help advocate. So as I'm sure many of you are aware, some of the community supports that are available will help people. And really, I think working with some of your fellow contact tracers and your contact supervisors will help to bridge some of those gaps. So right now, I just want to take a minute to engage in a small exercise of self-reflection. Self-reflection is a really big part of the the cultural humility process, and hopefully what you can do with contact tracing. Just take a minute to think of your own life, and one time in your own life, maybe that first time that you were ever made aware that you were different from a group of people. Maybe it was in school, maybe it was friends, maybe it was within your own family. And think about how that experience made you feel. Did it make you feel vulnerable? Did it make you feel angry? Did it make you feel defensive? How did it feel to know that what you had taken as normal might not be normal for everybody else? And think about how that might feel within the context of something as serious as a global pandemic. And that's what a lot of the folks that you're talking with may be feeling, that their lives have been upended, that what we take for granted as normal or assumed to be true may not be the case for them. And that kind of little exercise of self-reflection, just how would I feel? How did that make me feel? Really might help us to center the client in a lot of our work. Now, I've mentioned that a lot of this work that we're going to talk about has been impacted by health disparities and health inequities. I'm going to turn this over to my colleague, Neveline White, who's going to explain a bit more about what we mean by that. Neveline?
Thanks, Megan. So health disparities. A health disparity is a particular type of difference in health or in the most important influences on health that could potentially be shaped by policies. It is a difference in which disadvantaged social groups systematically experience worse health or greater health risks than more advantaged groups. We have to keep in mind that disparities just don't happen. They're often man-made. They're the cumulative result of policies that are written and unwritten, intentional and unintentional, that disadvantage certain groups to maintain the advantage of other groups. They result in lifelong generational health outcomes. So it's important to realize and to know that these disparities, they do not have to be. They are created, again, by policies and procedures that allow them to be sustained. Next slide. Health equity. So health equity, right, is the attainment, right? It should be the attainment of the highest level of health for all people. And achieving health equity requires valuing everyone equally with a focus and ongoing societal efforts to address avoidable inequities, historic and contemporary injustices, and the elimination of health care disparities. We have to keep in mind that equity is a more of a strength-based approach. The achievement of health equity must be intentional. So we have to realize that health equity requires action. It's not something that we just think of, it's a great idea, but we need action behind it. We don't achieve health equity without deliberate, purposeful steps. So it's really required to understand that health equity is achieved by movement, by action, by policies and procedures. Next slide. This slide is an illustration of health equity. And if we take a look at the first, right, and this is equality. If we take a look at the first picture, we see that everyone, if you look at the blocks, right, everyone is given the same block. But if you look at the structure below, everyone is not beginning at the same place. So even though you've given everyone the same block, right, everyone is not at the same place. So equity assumes that everyone has equal opportunity. But we know history tells us that doesn't take into account for historical disadvantages and its impact. If we move to the second illustration, we see that they do take history into consideration, right? And so they understand that the structure below, it's uneven, so the blocks are representing that. However, if you take a look at the fence, and the fence represents the system, it's unequal. And so equity it's better, right? But it's not the best. And we take a look at the third illustration. It is really taking into account everything. It's taking into account that the beings are not the same. It's taking into account that people need different levels or degrees of support and help, but they are understanding that the system, which the fence represents, needs to be taken down. Justice means dismantling the system that perpetuates the inequalities. It allows it to continue. So in order for us to really have true equality, we must dismantle the system. So it's a great illustration of showing how health equity works. Next slide. And this illustration really talks about the root causes. What are the root causes for these disparities, these health inequities? And a lot of it is institutional racism, class oppression, and gender, and the impact that it has in power and wealth. And that impact that it has on power and wealth, it affects our social determinants of health. It affects the conditions where people live, learn, work, and play. So we understand that there's other variables that are in play that create these conditions. And the conditions that people live, work, learn, and play are not, they are being sustained by systems and laws and policies and procedures that are creating these conditions. And I think it's very important to note that so it helps us have a better understanding of why these disparities exist. Next slide.
Thank you, Neveline. And I think as you all see as we go through this presentation, we're going to talk a lot about the disparities and how they manifest, and it's something that's going to be really important to keep in mind as we talk to folks on the phone. So Neveline mentioned how health disparities and health equities manifest. COVID-19 has been kind of the perfect intersection of health disparities, health inequities. As you can see from this slide, both in New York City and New York State, COVID-19 fatalities have disproportionately impacted racial and ethnic minorities. Hispanic individuals account for 34% of fatalities in New York City when they're only 29% of the population, and 14% of the fatalities when they're only 12% of the population in New York State. Similarly, individuals identified as Black represent 28% of the fatalities in New York City, being only 22% of the population, and in New York State represent 18% of the fatalities, even though they represent only 9% of the population. So if we look at statewide numbers, you really see the significantly disproportionate impact that this pandemic has had on individuals who are Black and Hispanic. Why is that? Well, we can see that some part of that does have to do a bit with COVID-19 testing. We did see some disparities in testing. I think it's really important to understand that as we roll out policies and procedures, sometimes things can have unintended consequences. And obviously the focus of COVID-19 testing initially was to get as many people tested as possible. And that was an evolving process. And sometimes when we don't specifically center equity or implicit bias in some of our work, we can have unintended consequences. For example, some people experience barriers due to physical locations and setup. Many of the early testing sites were drive-through. And for individuals without regular access to a vehicle, that was very difficult for them to obtain. There was also concerns about costs associated with testing and treatment. For people who don't have health insurance or who may have lost health insurance because they became unemployed, early fears about whether or not they would have to pay really kept some people away from testing sites. We also saw disparities for those people who were recommended to be in isolation or quarantine. Some people live in multi-generational houses where they may be living with older relatives, younger relatives, extended families, and they're not able to find a place where they can actually self-isolate. I know we recommend that people self-isolate in a place where they have their own bathroom. If you live in a home with only one bathroom in the home for the entire family, that's not really going to be possible. There was also a lot of concern about access to medical care during the COVID-19 illness. Obviously we know that this hit New York City very hard, and so people were concerned about even going into the hospital. And underlying all of this is the generational mistrust of many institutions and health systems which have generationally and historically failed certain communities. So you have this pandemic that's making everyone concerned and everyone nervous, and it's further exacerbated by many of these social determinant issues. One thing we also can anticipate is that we might see some disparities in contact tracing. There can be a lack of understanding about the need of contact tracing. Reticence to name contacts, and we'll talk about where some of that comes from. And underlying all of this, again, is the mistrust of institutions and systems, which people may have had long-standing personal, familial, or generational bad experiences with. None of this has to do with you or I as individuals, but has to do with the larger systems that we represent. And it's really important to understand that for some of the people with whom we speak, calling on behalf of the health department, of a hospital system, of even the New York State government, can be something that instills mistrust and fear in the people we're calling. Neville's going to talk a little bit more about what social determinants actually means and how they can influence specific people. Neville?
Yes. So I think the best way to illustrate the factors that influence these outcomes and to really highlight that these disparities are not a result of any biological differences between people, but rather social determinant factors that impact health. So I'm going to give you a story. Let's say we have a young lady. She is a grocery worker. She works part-time. She's married. She has a husband who works in retail as well, and he works in, let's say, a Macy's. She works at a grocery store, and they live in New York City, any borough. They live in public housing, and there is, say, 6 family members in the home. So COVID has happened, and so her husband has lost his job, and she works part-time at the grocery store, but the grocery store is essential, so she's an essential worker, and she has to go to work every day. So her husband is unemployed, so he is filling out for unemployment benefits. However, they don't have a computer, so they are doing this on their smartphone, and they're getting by. We know that over 2 million people are trying to apply for unemployment, so it's hard. They're not going to get their funds immediately, but they will get them. But that's on hold. So now she's an essential worker. She's going to work every day. She has to go to work because she's the only sole provider for her household at this present time. And in addition to that, she's essential, so she has to be there. She doesn't have a car, so she has to go on public transportation in order to go to work. She lives in a housing development with over 20-something floors, and each floor has about 15 apartments on the floor. And so she gets up every morning. She's a hard worker. She gets on the train and the bus to get to work. And this is before the mask. So she was going to work without wearing masks, but doing all the different things that that the government was trying to tell her to do. She worked in retail, so she's around a lot of people. She's diabetic, but she's taking her medication. She's a little concerned because her husband, she didn't have health insurance. Her husband has lost his job, so she no longer has health insurance. So she's coming back home to this apartment with her mother, her grandmother, her sister who is pregnant, her husband, and her children. So her husband, the money's not coming in because we're waiting for unemployment. It's going to come, but it's not coming yet. So she's picking up some extra hours to work. She doesn't feel well, but she can't take off of work because she has to work because she's the only income. At this present time, they don't have a lot of money coming in, so most of the money is going to food because now everyone's home. Everyone's quarantining. Everyone's New York pause. Everyone's home. So the food bill has increased. She lives in a community where the prices are already higher, and price gouging has happened. So now food is, there's a lot of food. Thank God there are some churches, some pantries that she can go to help get by. But because she's trying to make food stretch, she's buying rice and potatoes and things that make food stretch that may not be good for her diet. She's a diabetic. Her sister is pregnant. She's in the home. She's trying her best, but she's scared because I don't want to go deliver a baby, right, in the hospitals that everyone is dying. The grandma, she begins to get sick. They worry. She strikes a fever. They have to take the grandmother to the hospital. The hospital is not the best hospital in the neighborhood, but that's where they have to go because they don't have any means to go anywhere else. And so they go to the hospital. They leave grandma there. Everyone's stressed, concerned. The cortisol levels are rising because they're concerned about grandma. We have to leave her in the hospital. We don't know what's going to happen. The pregnant sister, she's getting sick, but she's too scared to say anything because she doesn't want to go to the hospital to deliver her baby. And meanwhile, she has to continue, to go to work because she can't take any time off because she doesn't get paid. She doesn't, get paid if she doesn't go to work. And these are the conditions in which people live. As she goes to work, she's in a crowded elevator. She lives in a housing development where there's tons of people, the density of where she lives. She doesn't have the means to leave her home. She has to quarantine in the home. She doesn't have the means, she doesn't have a second home in, say, the Hamptons, or a second home in Martha's Vineyard or Columbia County. So she has to buckle down and quarantine there. They're still waiting for the unemployment. It hasn't come yet. She's picking up some extra hours. She, too, isn't feeling well, but she has to press on because she has to go to work. Meanwhile, the grandma is in the hospital, and we don't know what's going on with grandma. We can't get there to her. My sister is very sick. She becomes ill. Now she, too, has to go to the hospital, and she's nervous, and she's scared because she has to deliver the baby. So these are some of the conditions, right? These are some of the variables that are happening, families all across New York State. And I just picked in New York City, but this can happen in any part of the state, Western New York, Central New York, even in the North Country. There might be some different variables, but it's the same. People, the conditions and where they live, they cannot successfully, right? They already had issues before COVID, and now we have COVID impacting on that. She has diabetes. She no longer has health insurance. She has to continue to go to work. Her husband is out of work, so their health insurance has stopped, and so they're scared to even go to the hospital because, A, COVID is there, and also, two, how can we pay for this? So this is what happened in many households, and again, it is not because they're black or Hispanic, but it is because of the conditions in which they lived. And then you place COVID on top of that, and it's just breaking the system. And they have many other people within these communities, right, that are living amongst these conditions. And so grandma has passed away. She has succumbed to COVID, unfortunately. So we're stressed out, the trauma, the grief that we're dealing with that. But meantime, I still got to continue to go to work because I still got to feed my family. And I don't even have the time to grieve grandma. And I'm so concerned over my sister who's in the hospital, possibly giving birth. So this talks about the different variables and the different conditions that people are in. Next slide talks about being overrepresented in jails and prisons and the concerns and issues there. Many of the essential frontline workers are black and Hispanic, and they're very hard workers. They're working really hard, but they don't have the protective factors to quarantine in place. So that was just giving you a brief story of some of, again, the conditions, and really stressing that it's not because they are black or Hispanic, but it's the conditions that they live in, that they work in, that they play in, that are exacerbating COVID-19 and the concerns there.
Thanks, Neveline. And I think that was a great way to segue to our next conversation, which is about the concept of intersectionality. Audre Lorde, the brilliant academic, really kind of said it best, that there's no such thing as a single issue struggle because we do not live single issue lives. People are more than just one point of demographic information that we may have on them. All those different things that Neveline talked about, where people live, with whom they live, what they do for a living, the quality of the neighborhoods in which they live, their proximity to a grocery store or to a hospital. All of those things impact their beliefs and their behaviors when it comes to health and healthcare and accessing health services. So we're going to talk a little bit more about some of these intersectional issues. Excuse me, you can see here, think about this figure that we have on the slide. There are all these different factors that comprise this one person. And you have to remember that all these different systems we operate in, whether it's systems related to racism or gender and class exploitation, any other forms of oppression, they don't work independently on one another, but rather kind of cumulatively on top of each other, happening to people simultaneously and exponentially at the same time. So I want to do another just short little thought exercise. Think of yourself as this person in the drawing. And I want you to think of your three closest friends, three people that you're not related to, but they're your three closest friends. Picture those people in your mind, and I just want you to think in your head, are those people the same race as you? Do those people speak the same language that you do? Do those people have the same level of educational attainment? Do those people share your marital status? Are they all single? Are they married? Are they divorced? Do those people share the same sexual orientation as you? How representative of diversity is that immediate friend group? It's very common for us to choose to be friends with people with whom we share a lot of commonalities. They may be people of our same educational level. They may be people with the same sexual orientation. They may be people who share our language or our culture. That's a concept called affinity bias, where we naturally gravitate towards people with whom we share an affinity for certain things. That is natural and that is human. But it also means that some of us have limited contact with people who come from different educational, cultural, age, ability, or class backgrounds. That's not uncommon for people, but it's important to recognize how our social circle and the people with whom we regularly interact may influence our concept of the world and how people act and behave. So what does this mean for us? We talked about how individuals with COVID definitely experience a lot of health disparities in general, and we saw the statistics that showed us that individuals from racial and ethnic minority populations and other cultural groups may be more likely to be infected or exposed by COVID-19. This also means that for all of you who are doing contact tracing, you are maybe going to be calling people who have an existing mistrust in healthcare systems and governmental systems way before the COVID-19 pandemic hit. And it's important to recognize that many of the people you're calling are experiencing these health inequities, and they're maybe more likely to experience other health inequities or other inequities in access to basic services and care because they're at risk for COVID-19. So Nemily's going to talk about a couple of different cultural groups, and then we're going to talk about how this will impact your work.
So the Black community and COVID-19. So the Black community was disproportionately impacted by COVID-19, and that is true. We see that in hospitalizations, we see that in infection rates, and even in death. It mirrors the disproportionate rates of other health concerns. So those of us that worked in public health was not too shocked by that point of COVID-19, because we understood and we know that Black people, in regards to maternal infant mortality, HIV/AIDS, hypertension, cancers, diabetes, that the disparity is huge and it's been used historically for a long time. And these inequities are rooted in racism and racist policies that were designed to negatively impact the Black community. And we talk a little about redlining, and we can really spend so much time, right? I'm not even giving this enough justice, but redlining, mass incarceration, slavery, and segregation, that these conditions, when I gave the illustrator about the young lady, she's living in where she's living because she wasn't given an opportunity to possibly live in another part of town because redlining occurred. And I want to say even in 2018, 2019, there was, in Long Island, there was some illustration of redlining still going on. So these things, this impact is still, we still see the impact. And then the everyday racism. In terms of the cortisol levels of African Americans are extremely high because of the everyday racism. And it could be you're walking down the street, someone grabs their purse. You are a young Black male and you're viewed a certain way. When you walk into the store, people are constantly following you. When you're going to the doctor, you're asked certain questions that others are not asked, assumptions that people make about you because of the color of your skin. And over time, you're constantly fighting. You're constantly in a defense mode, and it raises your cortisol levels, which impacts your health. And so we talk about the Black community really, really being hit hard when it comes to COVID, but that's because we see the other inequities that we were hit hard because of all the other inequities that are coming into place. We talk about the Jim Crow laws and the impact that has on the Black community even today. And even though some of these things are no longer on the books legally, we know that it still plays out within the Black community, which affects their health. And COVID-19 just exposed the ills that we already knew that was happening within the community. Next slide. Many other minority groups were affected. Many Asian Americans had experienced racist treatment and discrimination, in some cases even hate crimes, because of believing that they brought COVID-19 here to America. Native American communities have also been devastated by COVID-19. We haven't even begun to understand and to see the Native American, the devastation that they are facing with COVID-19. And all of this, as the world watches the murder of George Floyd and other murders by police officers, even in New York State, Eric Gardner, we had our own case here in New York State. So you now have all of this happening at all the time. And again, like Megan said, the mistrust of the medical community prior to COVID, and now you have COVID, and now you have the oppression and the murdering of black men systematically. This is going on at the same time. And you have to remember, right, so you're going to be contacting family when this is going on in their world. It's a stress. It's a lot. And then here you come when I ask them about quarantining and being isolated when I cannot do that. And I'm scared. I don't want my son to be isolated. I understand he has COVID, but I'm afraid of my son, right, my young black male son going out into this world. So all of these feelings and thoughts that that families are feeling, right, and other racial economic minority communities are feeling as well, and you are going into their home representing the government, which many of these communities, and rightfully so, do because of policies and procedures, feel a mistrust towards the community. Next slide. Lower income communities. Lower income communities have been devastated to COVID-19 as well as other health outcomes as well. We also know that for the social determinants reasons we talked about before, dense population, multi-generational households living together, not having the resources, living in neighborhoods where there are not a lot of resources, going to grocery stores where they're smaller, they don't have the best fruits and vegetables, price gouging going on, and again, you're no longer working, unemployment is coming, your check is coming, but it's taking some time, and you don't have a savings account to go and pull money from to feed your family. So that is happening all simultaneously when you're giving them a call about quarantining. Also, too, many of the individuals already experiencing challenging accessing health care. Lower income folks are more likely to live in communities where public hospitals, and there is a feeling and thought that they don't get proper care in public hospitals, or if I'm on Medicaid, I'm not receiving those that of my other fellow citizens within the state. Native Americans, again, have been victimized by racism since Europeans colonized America, so you have that going on, as well as prior to COVID. Native Americans experienced disproportionately poor health outcomes and a wide range of disparities. So all of these communities, again, are feeling the weight prior to COVID, and then COVID comes, and then in the middle of that, you also have the surgence of bringing forth some of the racist things that are happening in the community, and you have the protest and the anger and the upset and the feeling of hopelessness, and all of this is all happening simultaneously to certain communities. Next slide.
And I do see just one question in the chat. Somebody asked for a definition of redlining. So obviously folks feel free to look up any of the terms that we use in this. I would encourage everybody to look it up after the webinar. But redlining was a process where federal-backed mortgages were not provided to African-American applicants if they applied to live in certain areas. Literally, there would be municipal or city maps where the federal government kind of outlined in red, and banks would do something similarly. They would use a red pen to cordon off what areas they would allow black applicants to apply for and receive mortgages to purchase houses in. And it was a way to use mortgages and the ability for people to actually purchase houses to keep neighborhoods segregated. And one of the things that we see in public health now is that you can actually sometimes take neighborhoods and you can take one of these old redlining maps from maybe the 1920s or the 1930s, and you can overlay those maps with a lot of the health disparities Neveline talked about, and you see that what that effectively did was concentrate racial and ethnic minority groups in certain neighborhoods that further concentrated poverty, as that kind of happened over generations and years and years and years. So, excuse me, for immigrant communities, as Neveline mentioned, many groups have been subject to racial bias and discrimination. Xenophobia and anti-immigrant sentiment and bias has increased over the past several years, whether or not somebody is an immigrant or just perceived to be an immigrant. A lot of people who may be immigrants to this country may be very suspicious of government and people asking for information. That could be because they've had negative or unsafe experiences with their country of origin. If you think of refugees coming from other countries where the government enacted violence upon its citizens, or where they may have not been safe talking to their own government. Also, a lot of people now are afraid of being penalized for using government services. Something called the public charge was discussed very publicly. The idea that if somebody applying for citizenship had ever used a public service like Medicaid or SNAP, that may detrimentally affect their ability to apply for and be granted citizenship. And then obviously for individuals who aren't documented, they may be very concerned about disclosing any information for fear that their documentation status would be noted in their file and shared with immigration authorities. To make it really clear, documentation status should not be noted or reported to anyone for any individuals that you come into contact with. That information may be important to know in terms of what health insurance options are available to them, but as it extends beyond the care that you're providing through your contact tracing call, we should not be asking questions about this or noting it. Another group of individuals to kind of keep in mind, LGBTQIA, lesbian, gay, bisexual, trans, queer, questioning, intersex, or asexual individuals. They also feel mistrust of government institutions. It wasn't until very recently that same-sex marriage was legalized. Literally today, there was a Supreme Court ruling that people can't be fired because of sexual orientation, which is sort of a huge deal, everybody. Individuals also who identify as LGBTQIA, they also have had very challenging or negative experiences accessing the healthcare system. This can be especially true for trans folks or gender nonconforming individuals. And to be clear, somebody who identifies as gender nonconforming or who is of a non-binary gender may be somebody who does not identify as either male or female. They may identify on a spectrum between male and female. They may identify as having no gender. They may identify as having multiple genders. There's sort of like a beautiful rainbow of ways that can manifest. But for some of those people, accessing healthcare can be very challenging. You know, if I'm a trans man and my name is Kenneth and I need to go in for gynecological services, I may experience a lot of discrimination. I may have a hard time getting my insurance to cover certain things. So you may be talking to people who've had a really difficult history with the healthcare delivery system. And the language that we use can also often unintentionally perpetuate biases. Just a few simple things that we can do. You know, ask if they live with a spouse or a partner. Don't assume a husband or a wife based on the gender or pronoun of the person they're using. Also, don't assume gender. You know, if we call someone named, you know, William Smith and William asks for you to use female pronouns, just she, her, and hers. It's a simple switch that affirms this person's identity, and that is a huge deal. And somebody's government name, the name that we have on paper, may not be the preferred name they use. So once you check and make sure, like, this is who you're supposed to be talking to, if they request that you refer to them by another more affirming name, that's just a simple change you can make that will make sure that the person you're speaking to is much more comfortable. There also are going to be, again, this is not meant to be an exhaustive list of cultural dimensions, but another dimension to think about are folks in religious communities. We have a very religiously diverse state, some communities live very physically and geographically isolated from other populations, and so they may not be familiar with like common colloquial terms or different kind of references or touch points that we use. Remember that some religious traditions do have rules or beliefs that relate to healthcare services. So, for example, in the Sikh religion, adults are not supposed to remove or change or alter any body hair anywhere on their body. And that for men typically means that they have, a very long beard. That can impact how they're able to use masks during the COVID pandemic. Gender roles can be different in religious communities. In some places, men may not want to speak to women and vice versa. That's something to kind of pay attention to and try to be respectful of as you can. And also bear in mind that religious observances may make contacting people difficult. In some Orthodox Jewish communities, the Sabbath starts on a Friday night, and from sundown until the next day, people may not be able to answer the phone or use any technology. People who practice Islam may pray 5 times a day and may not be accessible during their prayer times. So it's just important to bear in mind that people have different cultural considerations that may actually make getting a hold of them a little bit challenging. And for everybody you're talking to, remember that this pandemic affects not just our physical health, but our mental and psychological health as well. And I'm sure all of you in your personal lives are aware of this too. You may be calling somebody who has already passed away, and you may be talking to a family member. You may be looking to contact a person who passed away, or who may be too ill to actually come to the phone, and you may be talking to their family member who's obviously very upset or distraught. You may be calling people who have lost one or even more family members, friends, colleagues, acquaintances. People may be grieving. They may be angry. They may be frustrated. They may be, very upset because they feel the system failed them and their family. And then obviously the intersection of that experience with, the murder of Mr. Floyd and the subsequent national discussion about racism really has increased that stress for a lot of communities in New York State. So, we're going to talk a little bit more about what we can do, but really leading with empathy. I found this diagram and I really loved it, just to kind of always keep in mind, seeing the world through the client's eyes, really appreciating them, understanding their feelings, and just working and using those active listening skills to try and communicate understanding. It's not important that you know every answer, but that we communicate our desire to understand and be supportive of people. So right now, I'm going to turn it over to Pauline and Simone, who are going to speak about how this impacts the work as contact tracers.
Hello, everyone. It's Simone speaking. So I'm going to talk about first some aspects to keep in mind include the historical distrust that the Black community, the Hispanic community, and other marginalized groups have had with the public health care system due to certain medical practices that were rooted in racism. So the first that I want to discuss is the Tuskegee experiment. And beginning in the 1930s, African-American men were unknowingly infected with syphilis as part of a project that lasted over 30 years to study the long-term effects of syphilis on people. These men involved in the experiment were not told about being infected. They were also unknowingly passing the disease to their partners because they didn't know. So, and this information was not disclosed until the 1970s. They didn't know about it until over 30 years later. So this is one example of why certain communities, like the Black community, have a historical distrust in the public health care system. Another example includes J. Marion Sims. So he is known as the father of modern obstetrics. Many of his innovations and surgical procedures were developed and practiced on enslaved women. These women were often operated on without anesthetics, even though it was available at the time. And many of his counterparts and colleagues at the time found his behavior unethical and cruel. A statue of Dr. Sims was in Central Park by the New York College of Medicine and has been taken down since uncovering this information that was in history. And then another case includes Black maternal mortality. So in New York State, Black women are currently 3 to 4 more times more likely to die from a pregnancy-related issue than white women. In New York City, Black women are up to 12 times more likely to die from a pregnancy-related issue than white women. And this mortality rate exists across all economic, educational, and social groups within the Black community. And lastly, another example includes the Puerto Rican sterilization project. Postpartum sterilization occurred frequently from the 1930s and 1970s. It was known as La Operación. It was common, and women were often not adequately consented. So all in all, these 4 examples are 4 of many examples that were historically used against people of color and marginalized groups in the public health system. And then next, we have something else to keep in mind, includes living environments. Some people may live in multi-generational households with very little room. They may also live in neighborhoods and communities where they don't feel safe walking outside in the hallway, in the street to take your call. So they may live with family members or roommates without a space of their own, and they might not feel safe leaving their home or have anywhere else to go when you are calling. So that's something else to keep in mind. And then lastly, another aspect to keep in mind includes some family members of individuals who do not speak English may want to interpret for a family member. And even though this may seem easier, it may take less time. This violates the privacy of the patient. If you need interpretation assistance, call the language line. And this could put someone at risk for domestic violence or coercion from family members. If you speak the same language as the person you're calling for, you can speak directly with the person. But if not, then you're encouraged to use the language line. And now my colleague Pauline is going to take over.
Thank you so much, Simone. So another thing to keep in mind, some individuals may have spoken with someone from their local or state health department, but you may very well be the first person from a government agency that has reached out to them or their family since the COVID-19 pandemic began. Therefore, they may use their time with you to either talk about or get assistance for other needs. Those needs can include or range from medical, food, housing, domestic violence, especially since some people have no choice but to be home and quarantined with a potential abuser. But those needs can also range to others that aren't explicitly mentioned here. Keep in mind that the focus should remain on the substance of the call. Your job isn't to fix all those problems, but connect them to community support specialists. Next slide. Wait, what slide am I on? All right, following the previous slide, people may feel comfortable with you and they may disclose information that you may find troubling or illegal. If you're concerned about certain comments, safety, or other issues, please speak with your supervisor or community support specialist so they can help navigate through those scenarios with you. Information about immigration status should be kept confidential. You should also be avoiding conversations that digress into politics, refer to other individuals aside from the contact. You should not be entertaining biases or microaggressions that were discussed or anything inappropriate for that call. While all these topics arise, keep in mind that you are not law enforcement and your focus is on public health. Next slide. You'll have access to individual identifiers, so you'll be asking for the person by first and last name. Keep in mind that using casual or informal language can be a privilege. Not every culture accepts casual forms of address, and it may be rude to refer to an adult that you don't know by their first name only. So you should be listening to the caller, refer to them formally unless they request otherwise, and if they do so, go ahead and follow their directives. Next slide. And along those lines, and as Megan mentioned earlier, Another thing to keep in mind with names is that not every non-binary or trans person can afford to legally change their name. If they ask you to refer to them by another name or use their preferred pronouns, go ahead and do so.
So ongoing work. So one of the things that's really important that we need to center the client in all our encounters. And really what that means is that everything revolves around the client. So very important that we listen more than we speak. We're not that important. It's about the client. Listen to the client. And also you want to have a no judgment. You do not want to judge anyone. They may have questions or concerns or issues that may be reflective of their cultural background, belief, and their lived experience. And so when you encounter that, you want to make sure that you do not judge. And it's also very important. Remember the scenario that we gave. People are living with a lot of different variables and a lot of different stressors. So it's important, right? You don't want to be, they could be, really angry, really upset. It's important to have no judgment, but also to come to them with understanding and empathy. And really important that when we engage with people, that we have a spirit of understanding and a spirit of empathy when we engage with folks over the phone.
So just keep in mind, a good way to kind of check ourselves and keep this at the forefront of our work is to think about ourselves. Think about your own culture, how it impacts you, how it helps you complete your work, how it contributes to what you think and feel. Be open to feedback from either the people on the phone or the folks that you're working with. Recognize this is an ongoing process, and share what you've learned. You and your fellow colleagues are going to talk to a lot of different people, and it's important to make sure that you share some of those experiences. And take some time to debrief your encounters, especially the difficult ones. There's a lot to learn. As you go forward through this process, I encourage everyone to kind of continue to engage in this ongoing self-reflection I mentioned. A big part of cultural humility is understanding yourself and checking yourself. So these are just 4 things to think about. Identifying your own beliefs, defining your own personal culture so that you're aware of it and that you can become aware of any of your own personal biases or assumptions. And then challenge yourself in identifying your own values as the norm. Recognize that they are unique to you, to the lived experience and to the expertise that you bring, but they're not necessarily going to be shared with everyone. Now, I just want to say we are getting a lot of questions in the chat, which I appreciate and I love them. Unfortunately, we don't have time to answer them all today. So if you have further questions, type them into the chat. We will share them and try and get answers out to you. I believe I'll double check. I think we may be able to share a copy of the slides with folks. And again, keep your questions coming. I think I just want to make sure I just see one question about the debrief. I mean, we're talking about debriefing, with your colleagues, with the contact tracing people like your supervisor. You never want to be in a position to share confidential information with other people that are outside of this process. But if you've had a difficult call, if you have some questions, that's what your supervisor is really there for. And they're a wonderful asset for you to debrief, to share some of this experience with, as it may be helpful for other colleagues. So please, if you have questions, type them into the chat. Share them with your contact tracing supervisor. We will try to get you answers. Like I said, I believe that we should be able to share a copy of the slides with folks. And thank you again for taking the time to join us on this training today. And thank you for being part of this process. It's so important to everybody in New York State, and we appreciate all of your hard work. So thank you very much and have a great day.
Ladies and gentlemen, this concludes today's conference call. Thank you for participating. You may now disconnect.